Good afternoon, everyone, and welcome to our final HC3 convening of 2024. My name is Megan Phillip, and I am the Executive Director of the Healthcare Council of Chicago. HC3 is a collective of Chicago-based organizations working together to drive meaningful change, improve health outcomes, and address the challenges impacting our city's communities. We are proudly managed as an initiative of Third Horizon, a boutique advisory firm shaping the future of healthcare locally and nationally. As we close out 2024, today offers a moment to reflect on the year's challenges and achievements in healthcare across Chicago and Illinois, and to look ahead to what's next. I'm excited to have such a diverse group of experts with us and immensely grateful to have all of you present here. This is the HC3 Podcast Live Edition, and I'm your host, Megan Phillip. Thank you so much for being here today. Normally, I am the interviewer and host, but today's special edition panel discussion, I've asked some friends to help me out. So it is my pleasure to introduce Ryan Voiles, who is a reporter for Health News Illinois, one of HC3's media partners, to lead us in a dynamic discussion with our panel of experts on healthcare in 2024. A warm welcome to our panelists, Dave Gomel, CEO of Rosecrans Network, Carolyn Metnick, partner at Shepard Mullen, Esther Mascione, co-founder and principal at Prestige Health, and Jordan Powell, senior vice president at the Illinois Health and Hospital Association. Thank you all for being here today, and take it away, Ryan.
Awesome. Thank you so much, Megan, for the warm introduction. And I've never done a live podcast before, so hopefully this goes well. I want to start off, and I want to give each of our panelists a chance to just do a little introduction, just introduce yourselves, what your current role is, and let's maybe just hit on a quick highlight for you as far as healthcare trends for 2024. And Esther, you're in the hot seat today, so I'm going to give it off to you.
I'm Esther Mascione, co-founder of Prestige Health. We co-founded Prestige Health with my business partner right there, Jim Chiamos. We actually are an advisory and consulting firm offering strategy, execution, and business development across the healthcare continuum. So our payers, providers, FQHCs, et cetera, are the type of clients that we have within our portfolio.
Wonderful, great. Jordan?
Good evening, everyone. Jordan Powell. I'm Senior Vice President with the Illinois Health and Hospital Association. And for those of you that aren't aware, IHA, we are a trade group that represents the interests of more than 200 hospitals and nearly 40 health systems throughout the state. And specifically, I lead IHA's health policy and finance team, where I work closely with our government relations team on issues like hospital funding, commercial payers, Medicaid payers, workforce issues and challenges, equity, and more. And I think there's really been a primary focus in 2024 on the practices of Medicaid and commercial payers, particularly around their prior authorization practices. So our organization worked closely with the Illinois Department of Healthcare and Family Services, that's the state agency that oversees the Medicaid program, on some really comprehensive Medicaid MCO prior authorization legislation. We also worked closely with the governor's office on the Healthcare Protection Act, which brought about some much needed reforms on prior authorization around, again, Medicaid and commercial payers, especially around behavioral health. So look forward to the conversation this evening. Excited to be here. Thanks, Ryan.
Awesome. Thank you, Jordan. Carolyn?
Thank you. My name's Carolyn Metnick. I'm a partner at Shepard Mullen here in Chicago. Shepard Mullen is a large international law firm. I'm in our healthcare group. My practice focuses on privacy, health information privacy, innovation. I founded and I lead Shepard Mullen Healthy AI, which is our AI initiative that's focused on healthcare organizations and stakeholders, and we advise clients and talk about AI and all things innovation. So really happy to be here today. Thank you.
Great. Last, certainly not least, Dave.
Hey, everybody. My name is Dave Gomel. I work as the president and CEO of Rosecrans Behavioral Health, which is headquartered here in Chicago, Rockford, and Sioux City, Iowa. We have 60 locations within 3 states, Iowa, Wisconsin, and Illinois. We serve about 65,000 patients. We have 500 plus beds, 300 some outpatient groups, a big audience. revenues just about 165 million a year. So we're nonprofit, but we're a big nonprofit, and we're very grateful to be here. Transformation, I almost forgot. We just announced an affiliation with another nonprofit, which is something that's pretty important to us to continue to reduce overhead by scaling in that regard. And for those who know, in the state of Illinois, we just launched the CCBHC Certified Community Behavioral Health Clinic, which is a game changer for the state of Illinois.
Dave, let's stay with you for a moment. Let's talk a little bit about payments themselves. And I wonder if you could just talk a little bit about what payment models have been the most effective in supporting Rosecrance's mission to deliver high-quality behavioral health services, and how are they contributing to sustaining your programs over time?
I think at Rosecrance, the secret of our success is really similar to how you diversify your portfolios, your 401ks. You want to have your funds in a lot of different areas, so if one's doing poorly, the other's picking up. And with our diversified portfolio in different states, different funders, we have a variety of lines. We have a community line, community mental health. We also have a private practice model, psychiatry, ME, the whole gamut. When I was doing poorly, Illinois seems to be doing well, and vice versa. And I think that has sustained us probably more so than anything.
Definitely. And Dave, talking about that, kind of what challenges do you face regarding city, state, and federal funding and budgeting, as well as just the reimbursement rates?
You just answered your own question. There is not a healthcare condition that's stigmatized like behavioral health. Any other disease that we have and that we treat in the medical field, we're always saddled with some kind of moral or willpower issue in behavioral health. And so I think it's easier to underfund our systems. And network funding adequacy is probably the most important thing. I'm constantly thinking about it and constantly talking, because if you want a good, healthy community, it has to start with behavioral health. If you want to provide behavioral health, then you have to pay people a decent living wage, God forbid, the ability to actually advance in their life. So that's our challenge and our opportunity.
Fantastic. Jordan, you mentioned funding a little bit earlier, and I want to go back and circle back on that. Just what are some of the significant challenges that hospitals in the state are facing right now, and how is that affecting their financial sustainability?
Yeah, that's a great question, Ryan. And I was reflecting on this year. So this week is my 4-year anniversary with the Illinois Hospital Association. I can tell you in those 4 years, I discovered there's no shortage of issues facing hospitals day in and day out. But when I think about challenges that are having an impact on financial sustainability, I really think there are 3 key issues. The first I already mentioned, and that is the administrative burden and the administrative costs associated with the practices of insurance companies. And I don't mean to pick on insurance companies, but this is a significant issue. Our hospitals have had to hire entire teams to address the unreasonably high percentage of prior authorization and claims denials. And not all of our hospitals have those resources. They don't have the resources to hire entire teams. And these insurance companies, they know that. So this is a really big issue. I mentioned the legislation that we passed earlier this spring. It was signed by the governor. We're continuing to work with HFS, and I think we've got a lot more work to do. The second challenge is related to the 340B drug discount program, where we have pharmaceutical manufacturers that are restricting the number of pharmacies that covered entities like an FQHC or a hospital can contract with to dispense life-saving drugs to those that need it the most. And that's why we've seen several other states pass legislation to restrict pharmaceutical manufacturers from these practices, because this is not only having a financial impact on covered entities like hospitals and FQHCs, but again, it's an access to care issue, access to medication issue for those individuals that are the most underserved in our state. The third challenge, and I'm not going to go into too much detail about this, is the negative medical liability environment in Illinois, and I will say it is very negative here. Now, as far as Medicaid and Medicare rates, we worked in 2023 with HFS to increase Medicaid hospital rates by 10%, so we were pleased to work on that. We were pleased to work earlier this spring with HFS on increasing physician Medicaid rates to 70% of Medicare. When it comes to Medicare and Medicare payment issues, I'm less concerned about Medicare payments and rates, and again, the increased amount of Medicare Advantage plans that we're seeing, because we're experiencing the same challenges with Medicare Advantage plans that we experience with Medicaid MCOs and commercial plans. And I see some head nodding and I see some head shaking, so we don't always agree on this issue, but I think we can all agree that more work needs to be done in that space.
Definitely. Esther, I want to go over to you here. From your strategic consulting perspective, what value propositions and strategies are proving to be the most effective in bridging providers and MCOs to create impactful collaborative models?
Yeah, that's a fantastic question. I love it. What I actually want to talk about a bit, which is the healthcare transformation collaboratives. Many of you may know what they are. They are actually administered by the Healthcare and Family Services. They're grant-based collaboratives where there's multiple different collaboratives across the state. I've had the privilege of working with several of them. And they're hospital-led collaboratives with FQHCs, federally qualified healthcare centers, social service agencies, different mental health providers, et cetera, that are part of these different collaboratives. And what I've seen with them as part of value-based strategies and innovative approaches is they're forming of togetherness and trying to find a way how to be financially sustainable, which we know is very difficult in the healthcare space today. So knowing that and trying to couple that by still providing the wonderful services they do, from employment, or I would say recruitment of a workforce of community health workers, trying to really establish a model where they can go to payers, MCOs, managed care organizations, and find a way how to contract to make sure that they are being incentivized for the work they're doing. So, when I think about the MCOs, I think about the world where, honestly, provider direct care is not what they do. But now trying to put together this siloed approach of community-based organizations, social services, behavioral health, hospital systems, and primary care with MCO, I think that's a very good path for value-based outcomes.
Definitely. And Carolyn, I want to go over to you. I did not intentionally skip you, but I just was curious, just what role do privacy and security considerations play in structuring payment models for digital health initiatives? And how can organizations ensure compliance while still advancing value-based care?
That's a great question. Value-based care arrangements are extremely data-driven, as you can imagine. And with data comes privacy considerations, HIPAA considerations. And I often get brought in to sort through the different data flows and help to find compliant pathways to move data where it needs to move. So certainly, what role do the considerations play? A significant one. Unfortunately, these are sophisticated issues. I'll look at it and I like to draw a map, right? What is the pathway here? Is this payment? Is it treatment? Is it a healthcare operations exception? And what hat is the entity wearing? Are we wearing a business associate hat or a covered entity hat or both? And there's a lot to consider, and it makes my job fun. And I'm not an expert in value-based care, which I think actually really helps me when I come in, because I can just look at it from a HIPAA angle and from a privacy perspective without understanding all the payment arrangements. So important considerations to answer your question.
Fantastic, great. And Carolyn, I want to stay with you because I want to switch over to one of the other big healthcare trends, not only in 2024, but in past years, workforce. And I was just curious, how are healthcare organizations improving workforce training to address the complexities of HIPAA compliance and cybersecurity in this increasingly digital healthcare environment?
I was remiss in answering your question when I introduced myself, which was what was a trend in 2024. An unfortunate trend has been the increase of cybersecurity incidents among healthcare providers. That is a huge trend. This year, we saw so many that just about impacted everybody. I don't have to name them. And the trend is continuing, and these breaches are becoming really expensive. So what kind of workforce training do we need? We need ongoing training about privacy and security, obviously, but sometimes these things just can't be helped. An IBM report recently showed that the two threats to hospitals and healthcare providers are social engineering and ransomware incidents, right? that doesn't sound unusual. That shouldn't surprise us. So we need to continue to train people on social engineering emails and how to respond to those. But again, I think the training's only going to go so far, unfortunately. Organizations need to be doing security risk analyses and all sorts of other things to make sure they have a great cybersecure infrastructure. In terms of training, I think we're going to start to see more training around AI. As I mentioned, I'm working with clients now in the AI space. Clients are developing AI, they're deploying AI. Where they are deploying it, they need to train people, right? So clinicians who are going to be using AI need to understand what they're using, and sometimes you can only understand so much, but providers do need to be educated in the weaknesses of the AI, the risks, the benefits. They need to be able to communicate this to patients where they are using it in a clinical setting so that they can obtain informed consent. And then we need to be generally trained on AI at a base level, because we're using it throughout the workforce, maybe just for more mundane and routine tasks, right? ChatGPT. So I think we'll start to see more training there, and it's necessary.
Definitely, and just a heads up to everyone, I want to put a pin in the AI discussion. That will be coming up very shortly for the rest of our panelists. But Dave, I want to go over to you on the question of workforce. And just what are some of the strategies that Rosencrantz is implementing to recruit, retrain, and support a skilled workforce that's capable of meeting the growing demands that we've seen for behavioral health services? And maybe if you could touch specifically on rural and underserved communities.
That's a long question. Yeah, this is going to be the least or most sexy story you're going to hear. Rosecrans originally was founded in Rockford, and I followed my partner of 33 years who was from Rockford. I was from Evanston. I thought Rockford was Iowa. And I got a job at Rosecrans when I was 23, and now I'm 54, and fell in absolute love with this mission. Started minimum wage. We got married, we raised a family on limited income, and so I knew from the ground level what I needed to feel supported. I needed to feel like I had an ownership, that I could use my passion, and I needed to be paid effectively. So when I took over as CEO, I remember when you started, Jordan, about 4 years ago at the same time, and they said, what do you want to do? This is COVID. And I said, I want to give everybody a raise, a big raise. And we did. We put a $6 million raise, which is now $23 million 4 years later. We've had the highest level of staff satisfaction that our company's ever had. We've had the highest level of staff retention, the highest level of rehires. We lost money 2 years in a row. Last year, we made the highest margin we've ever had, and we're on pace this year. Someone said, what's the secret? And I said, it's not magic. You invest in your employees, and you tell them you love them, and you tell them you're going to give them everything you can, and you show it. They're going to stick around and work harder. All right? There's never a lack of demand for our service. There's always a lack of supply, and you're going to hear that over and over. So to invest is important. A follow-up to your question has to do with the legislators and what are we doing in that regard. In 30 years, I've seen some horrific administrations. I've seen them decimate behavioral health. We are in, I think, the best time ever with our legislators, with our support from the administrative offices. They all get this, and they all support this, and they all realize $40,000 a year is tough to raise a family, and so we need to continue to invest in there. And so we're working with our managed care companies, with our state legislators, to try to continue to support them as we grow.
Thank you so much. Jordan, I want to go over to you. Just what are some of the biggest challenges that hospitals face in recruiting and retaining healthcare professionals? And just what are some of the either policies or funding solutions that IHA is advocating to address these?
Yeah, I'm going to try and condense this because when it comes to workforce challenges for hospitals, we could spend an entire session just on that. But there was already a significant shortage of healthcare workers prior to the pandemic, and that was only exacerbated by COVID-19. So piggybacking off what Dave said is that there's a significant demand for healthcare workers, but a limited supply. So I know this is a primary focus for our hospital members right now. They're working with their local schools and communities on pipeline programs. They're offering tuition assistance. They're offering student loan repayments and incentive pays and all the things that they should be doing. So this work is ongoing. But I think another challenge when it comes to recruitment is the amount of time that it takes for a provider to get licensed in Illinois. And this is especially for our hospitals that are competing with other hospital systems along the border, where it's taking 5 to 6 months for a provider to get licensed in Illinois, and across the border, they're getting licensed in a few days or a few weeks. So it's really difficult in terms of recruitment. Now, I know that we've worked with the governor's office, we've worked with the legislature and IDFPR, which is the regulatory agency that does the provider licensure. They've procured a new licensing system that we hope is up and running by next fall. And so we're hoping that those providers get licensed within a few days. Now, when it comes to retainment, that's also challenging. And you just look at nurses, because we tend to focus on nurses. Even though there's a significant shortage across the healthcare spectrum, we tend to focus on nurses. Nurses have more options these days, right? They can become a travel nurse, they can work for a private company, they can go work for an insurance company. Again, there's difficulties in retainment there. But another issue that I wanted to highlight that many of you may not be aware of is the violence that is occurring every single day against healthcare workers in our hospitals. I will tell you that every week I hear of a new assault by a patient or one of their family members or one of their guests against a healthcare worker. And I'm not talking about verbal assaults or simple shove. I'm talking about broken bones, concussions, injuries that require serious surgery. So this is a really difficult challenge for us when we're trying to retain our workers and we're having trouble protecting them. Now, I will say our hospitals are investing heavily in training and education and security technology and increasing the physical presence of security on their premises. And I'll say at IHA, we're working with our state legislature and the United States Congress to advance legislation to protect healthcare workers. Now, also, I have a policy and government relations background, and we like to solve problems, right? There's not one policy solution to workforce challenges. There's not a bill that we can pass that's going to fix all this. But I think what you will see in 2025, Ryan, is legislation advanced by IHA that creates a path so that we can start tackling these issues as a whole and not with a piecemeal approach.
Fantastic, great. Esther, I want to go to you. Just what are some of the strategies that you're prioritizing to advance workforce development, particularly in integrating community health workers?
I think, no, that's a great question. And I think where I've experienced is, again, I'm going to use the example of a transformation collaborative and how we were able to successfully hire, recruit, and build a curriculum for community health workers. We know that they are the future when it comes to providers. And ensuring that we not only build that infrastructure and workforce, but that we are in lockstep with the Department of Healthcare and Family Services to support them operationally, to ensure that they're ready to be the provider that needs to be credentialed through the state impact system, that needs to submit a claim eventually. This is all going to be very new for them. So I think what I've been doing, and also my colleagues within Prestige Health, is really looking at ways how we could be creative with alternative providers. And at this point, we know how important and critical community health workers are.
Fantastic. Esther, I want to stay with you. I made a promise I would go back to AI. We are on the AI topic. And I just want to ask you, are any of your clients leveraging AI to identify and prioritize the individual's needs based on social risk factors? And how is that technology driving that transformational effort?
Yes, absolutely. And I think more and more, I would say, providers are doing this. In this particular example, one of our clients in the south side of Chicago is really into understanding and predicting the individual's well-being, the whole person care. So we're not only dependent on claims data, we're not only dependent on what we have available, but they're looking at more than just the medical piece. They're looking at besides the curative care, they're looking at the whole social or health-related social needs, I should say, is the new term. But what's really important about that is that they are now working with a technology or AI platform where they're offering data scientists coupled with predictive models and really consumer, I would say, direct data where it's not just from claims. They're pulling information from the local public health department, from, I would say, TransUnion, Experian, whatever that may be. Those sources will really help care managers, caseworkers, community health workers, whatever the workforce is, to really prioritize those interventions and make them meaningful and direct for that individual. So I'm glad that this is now moving forward in that way. But yeah, I see AI actually evolving, advancing, and many of the providers and collaboratives are utilizing it.
Fantastic, great. And Carolyn, we discussed this a little bit already, but just how can healthcare organizations navigate the regulatory complexities of implementing AI in care delivery, particularly when balancing data protection requirements with the potential for improving access to quality care?
It's another lengthy question. There's a lot there to unpack. The AI landscape is slowly evolving. I think what we're going to start to see, and we're already starting to see it, is a patchwork of state laws, just like we've seen in the privacy consumer space over the last few years. We still don't have a consumer privacy law that's federal, right? We had CCPA, and then we have all these other state laws cropping up. Everything was very stagnant for a while for privacy lawyers, and now there's so much to stay on top of. The same thing is going to happen with AI, right? Because we're not going to have federal AI legislation. We probably will have it sooner than the consumer protection law, I think. But with the change in administration, I think that may slow. But we're already seeing laws pop up in states like we've got a Utah law, we've got a Colorado law, we've got California laws. And I'm just talking about the ones that I think are really impactful or really noteworthy for healthcare providers and healthcare clients. But we need to be monitoring these, and we are monitoring these because they're going to direct kind of what you do in that state. We're going to start to see them in other states too. A whole host of other states have them proposed. They just haven't passed. And of course, there are other state laws that aren't focused on the healthcare industry, but that need to be considered. I'm not even sure what the question was originally, but
No, I think you.
I probably digress. I think the job is to stay on top of all these developments, right? So that you can protect the data and comply with the law. And I also think you need to be, I'll just make one more point before I close, and that is, when you are negotiating with an AI vendor or you're looking at AI, there are complex data issues there. The vendors that are providing the AI want to take your data, and then there's always this pushback from the hospital or the provider that wants to have it. So pay attention to the intellectual property rights, pay attention to the data rights. That's always an area that's highly negotiated and really important. I'll stop.
Fantastic, great. Dave, I'll go to you. How is Rosecrans approaching the integration of AI across its network, and just what technologies are they exploring both internally and externally to enhancing patient care and optimizing operations?
So number one in community mental health is pay. When people leave, they cite pay. Number two is paperwork. Yeah, we have our chief of staff, one of the smartest people that I know, and she's constantly bringing me these new AI initiatives that happen. And she uncovered this ambient listening that some providers are starting to use. We're doing a session together. The computer is listening and documenting the progress notes as we go, which is less. They work for them. They put all their notes in, and AI can summarize and help create treatment plans as they go. We get 20,000 calls a month for service, which is impossible. And we're now using AI to help sort out and prioritize calls and move people into areas. Same with HR, with human resources, and trying to prioritize. So I think there is a lot of slippery slope, and I think there are people who are saying AI is the equivalent to a licensed clinical social worker. I don't believe that to be the case. I think there's a human element, but I think to augment and support is a pretty amazing opportunity to improve the job satisfaction for our workforce.
Fantastic, great. We only have a few minutes left, so I want to go to our last topic. And Dave, I'll start with you. Just a big focus here in Illinois, especially at the state level, has been with equitable care, making sure everyone that needs care can access it. And I'm just curious, just how does Rosecrans, especially considering the diverse political and social landscapes around the different regions you serve, how does Rosecrans navigate the discussions around equity and address the stigma surrounding mental health and substance use?
If you hit the far northwest side of Iowa, where Nebraska and South Dakota and Iowa meet, we're there all over. And one of the more conservative regions in the country. We also have sites in Madison and Chicago, which are not the most conservative sites. Imagine how popular it was when I mandated vaccines during COVID, with the exception of wear a mask and get tested. All y'all Chicago people thought I was weak. All the Iowa people thought I was the spawn of Satan. So it gives you the political landscape of what we look at. What's amazing is when we initiated our DEIB movement, not just for the inclusion equity of our employees and celebrate the employees, but the various clinically important needs of the variety of people that we serve across these 3 states. Not one pushback. Everybody understood that we need to celebrate the uniqueness of each individual and meet them where they're at. And it has been a beautiful movement, especially for someone from Chicago that's more on the liberal side. It's been beautiful to be a part of that, and I think it's been part of the success of our growth, where people feel welcome, and people not just are welcome, but they're celebrated for the uniqueness that they bring.
Fantastic, great. Jordan, I'm gonna give the final question to you, and just on the same topic, just what are strategies for the hospitals to ensure that they're able to continue to address care disparities and improve outcomes for those underserved communities?
Yeah, so I think what we've seen, and I've been reading, you've got some companies, I think they're confusing, or people are confusing DE&I with health equity. So you have some organizations that are scaling back on their DE&I initiatives. But when it comes to health equity, that's so critical to the mission of every single hospital in the state to provide care to anyone, regardless of their income, race, ethnicity, sexual orientation, gender ID. So what we've seen in Illinois is significant investment and engagement on the health equity front in both urban and rural areas, because this health equity impacts all of us, right? It's not really a blue or red issue. I will say for our organization, we launched the Health Equity Progress Report 3 years ago. So this gives our members a tool that they can identify their health equity initiatives and then measure progress over time. To date, we've had more than 80% of Illinois hospitals, so about 175 hospitals, have taken the progress report every single year. We also do health equity programming throughout the year. 85% of our members participated in health equity programming in 2025. So when it comes to strategies and partnerships, this is something that they're doing every single day, that they're investing in, and they've been doing it since before health equity kind of became a buzzword or a buzz term. We're happy to assist our members in those efforts, and again, I think it's core to their mission.
Fantastic, great. Everyone, give a round of applause. We had a fantastic discussion, and thanks our panelists for joining us today. And with that, I'll hand it off to Megan.
Thank you, and I want to give my thanks to Ryan for doing that. Now, as we transition to the second part of our program, it is my absolute pleasure to introduce two of the smartest Davids that I know. David Smith, the founder and CEO of Third Horizon and co-founder of HC3, who will be leading this fireside chat with David Johnson, author of The Coming Healthcare Revolution. Welcome, David and David.
So anybody that doesn't know Dave Johnson, you're in for a treat this evening. I met Dave for the first time, I don't know, 12 or 13 years ago, and Dave was an investment banker at BMO, working for the organization whose building we're in tonight. And did a bit with Dave for 2 or 3 years. We did some organizational work with BMO, and Dave was a regular attendee of these tabletop exercises we had at my former firm, Levitt Partners, and he would always bring such great insight and intellect, and then he would always go and write up like these 20-page summaries of what we talked about. Nobody asked him to do it, he just did it. And I remember I got some bad news one day that Dave was going to retire from BMO. So we were going to lose our anchor guy that we were working with at this big prestigious bank, and Dave was just going to go write in retirement. He's done doing investment banking and just wanted to write about the system. And I thought to myself, I'm not sure I'll ever hear from or see Dave Johnson again. And this is now your 27th book, 23rd? Fourth book. This is your fourth book. Dave sent me a copy of this in advance to read, and I tried really hard to read it before our discussion today. Anybody that knows me, you'll know that me making it to chapter 4 is actually a really big freaking deal, and it means I love the book. It is a good book. Dave, talk a little bit about why you and Paul chose to write this.
It's a funny story. My co-author, Paul Kusserow, is Rhodes Scholar, theology undergrad, literature at Oxford studying T.S. Eliot, and I'm an English literature major myself, and that's obscure. And he got plucked out of there by McKinsey to become just what the world needs, which is another strategy consultant. And along the way was...
We're in short supply.
Yeah, I know. Thinking the big thoughts, thinking the big thoughts. He was chief strategy officer at Tenet and then at Humana, so both payer, provider. I ended up as the CEO of Amedisys, the home health company, when it was an absolute dumpster fire. The stock was $11 a share. They just paid a big government fine. They'd fired the CEO. And anyway, they brought him in to clean it up. And once you get to know Paul, that's the only time you would ever hire him to be a CEO. Because he's got some pretty strong... Anyway, here we go. First thing he did was he went and spent 3 months in the field. We had a lot of talk about workforce development here. And he interviewed home health workers, went on home calls, clients, and so on, took a bunch of notes, and that became the basis for the strategic plan, which he called Golden Rule Management. Invest in your employees. They'll be great with clients. The company will do better. And anyway, he wanted to write it all up as a book. And he's a pretty good writer. He sent me like 200 pages of essays with one word that said help on it. And if I have a superpower, it's an ability to take massive amounts of information and make a cogent narrative out of it. So we did that. And then we're finishing off the book. And he writes 100 pages of policy stuff. And I'm on a plane reading it, going to his house in Maine. And I'm going, there's no way this is going in the book. And it wasn't bad, but his personal story was riveting. The company story was riveting. His strategies about how to turn around a company from turnaround to stability to growth to transformation, all really well thought out. That was the book. And it's a great book. It's called The Anatomy of a Turnaround. And anyway, I get out there and I say, hey, Paul, this policy stuff's not going in the book. And I don't know how many public CEOs of publicly traded companies, but they're pretty pampered as a group. Anyway, he got mad. He yelled at me, and I said, well, you can fire me as your editor, but as long as I got the role, it's not going in the book. And yeah, he stomped around. And anyway, he got over himself, and he finally said, hey, then we have to write a policy book together. And I said, let's finish this one first. And we did. And then ultimately, we decided to write the policy book together. And I was interviewing him on stage in a session like this in Nashville. And this is, I guess, a year ago, June. And we went back the next day, spent a day, and said, okay, it's a megatrends book. It's going to have 10 megatrends. Let's figure out what they are. And that's the book. So that's how it came about. The punchline, by the way, is more change in the next 10 years than in the last 100 years, and we can get into that. But what I've decided, you can see I'm wearing a suit and a tie, which I usually don't do, but I've decided my message is so revolutionary and on fire that I'm going to deliver it in as conservative appearance as I can.
I think the overall theme of the book being that we're going to see more change in the next 10 years than we have over the last century in American healthcare. Number one, I believe it, but there is that cynical voice inside me, Dave, that's been working in the field long enough to be a cynic. Yeah. And I think to myself, that was also kind of 10 years ago. I grew up working for Mike Levitt, who was a unabashed optimist about where our industry was going. And year after year, we don't really see, the only movement we see is the total dollar amount and the percent of GDP increases. We don't see temperance. We don't see the system regulating itself. Tell me what case do you make in the book that we will in fact see that level of change in the next decade?
Yeah, I mean, I walk that fine line between cynicism and skepticism on a daily basis. We can have a support group and help each other there. I found it, we had the 10th anniversary of Foresight in 2024. We got a couple of our people in back, Kelly and Dave. I don't know why they're not sitting next to each other. We'll get into that with that later. And what I'm saying, and it's to your point, the critique of the healthcare system really hasn't changed that much. What I'm saying today versus 10 years ago. But the big difference is 10 years ago, I thought the industry could change from the inside out. Obamacare was new. Accountable care organizations were sprouting up all over the place. We had big nonprofit organizations, mission-driven, saying the right things. I thought the industry was on a path to embrace value-based care, consumerism, better outcomes, lower costs, all of that. Fast forward to where we are today, if anything, it's gotten worse. We haven't improved at all. So the big change for me isn't the way the system operates today. It's my belief that the change that's going to come is going to be more outside in than inside out, and it's going to be really messy. So the industry, to some extent, has given up control of its destiny going forward. And the reason for the mega trends is 5 macroeconomic trends pushing down on the largest industry ever created by human beings. U.S. healthcare is bigger than the economy of Germany. Give me a break. And these forces, any one of them is powerful. The 5 together are irresistible. So it's demographics, funding fatigue, chronic pandemics, technological imperatives, and pro-consumer reforms, all coming down, and the system's starting to crack. And then the market forces bottom up. Markets hate a void, they look for opportunity, and increasingly the marketplace is figuring out ways to come in and fill in the cracks. And in the long run, it's going to be good for the American people. It's going to be better care, more balanced care between health and healthcare, lower cost, better customer experience, better overall well-being. But the road from here to there is going to be pretty messy, and we're going to slay a lot of dragons along the way. By the way, sacred cows make the best hamburger, in case you're wondering. First, you know what? I'm going to do a little interactive thing. I bet a lot of people that are out there saying, heard it before. So this is a little interactive. I'm going to ask you 3 questions. Okay, we spend 18% of our economy, just yes or no, raise your hands. 18% of our economy on health care. The next biggest countries spending the next highest percentages are France and Germany at 12%. Anybody in here think we need to spend more than 18% of our economy to provide great health care to everyone in the country? Anybody? Second question, according to the CDC, 90% of what we spend on health care goes to treat individuals with chronic disease and mental health conditions. How many think we're winning the war against chronic disease and mental health? Nobody. So here's the third question. On a relative basis, then, how many think we need to shift resources out of acute and specialty care into primary care, chronic disease management, health promotion, and behavioral health? So how long did that take? When you say it like that. Yeah. How long did that take? About a minute or so. So it's not the what to do, it's the how to make it happen. And believe me, we've all been going through the assassination of the CEO of UHC. And I have a piece out today called Social Media's Assassination of Brian Thompson. And I'm just trying to wrap my own head around the fact that here's a guy by every description that was a very decent human being, very accomplished, rose to the top of the company, and he gets killed walking to an investor meeting. And as this goes viral, he transitions almost instantaneously from a victim into a villain. UHC on their Facebook page had a condolences section, and they had to limit responses. I don't know how many of you have heard this, because after 80,000 responses, 75,000 were the laughing emoji. How did we get here? So part of what, and this is really your point, which is there is a huge amount of anger in the country about our inability to get this right. And I do think, and read the book if you can get there, but I do think the forces are aligning against the industrial complex to really do what markets do, and when governments act in sort of concert, deliver better outcomes, lower cost, better customer service. And I'll just say one other thing, and David, I'm going on long here, but if we continue on the current path, spending ever more money for a population, an ever sicker population, what does that lead to? That means, more isolation, less equality, lower productivity, less happiness. Who wants that for the future of the United States of America, right? If, on the other hand, we can actually figure out how to fix healthcare, and it is fixable, if we just collectively decided what we needed to do, then maybe we can bottom out of this rut we're in, begin to repair the social fabric, and get healthier together, and in the process get our mojo back and begin to tackle some other big problems that we have. So this is a big one. It's almost 20% of our economy. It's broken beyond belief. Incremental solutions on a broken system don't work. Changing the oil on a car with a shot engine isn't going to get you back on the road. So we got to do something different, to your point.
I wasn't going to raise the Brian Thompson event. I'm glad that you did, because I think it's an important moment. This is a moment where somebody in a premeditated way, we're learning more today how premeditated that really was, took it upon himself to do this. And this is not a defense of Luigi Macchioni at all, but it is emblematic to me that a lot of people interacting with our system get to a place where they feel powerless. My vote doesn't matter. I'm voting in favor of the things that I believe in, and I don't see change. There's no way I can reform the institutions I participate in because I'm given maybe 2 or 3 options at best to even choose from, unless it's just thrust on me. I don't have enough information to pick where I'm going for care. I don't get follow-up from that care. So I don't know Luigi's exact situation, if he was helping a friend or family or this was his back pain thing. But it does typify. People are getting fucking pissed about the system that we all find ourselves inhabiting. And that's the social media online commentary. Yeah, it's reprehensible, and it does show where we are a bit as a society when somebody, a father and a husband passes away from violence. But Dave, I'm trying to reconcile, when you talk about it's got to come from the outside, talk a little bit more about that. Governor Levitt always had this thing about economics and physics encapsulates these immutable laws, right? One thing happens, something else happens. That's just the law. That's what will always happen every time. Economics has the same immutable laws. They just have a lag. So what is it about the economic picture, either from consumers who are just getting pissed about the system, to the advent of AI, to the role of government? The system's not going to do it itself. Which of those forces are going to be the primary catalyst?
Consumers and markets, those are 2 pretty powerful forces.
When they work, but they don't work.
No, they aren't working. But anyway, let me talk a little bit about Brian Thompson and what this means before anything's really been sorted out. But I've actually been thinking about 2 historical events. I've been thinking about Lincoln's second inaugural address, and I'll come back to what that means, and then the outbreak of World War I. And what the hell do either of those things have to do with healthcare, right? So Lincoln's second inaugural address, it's etched into the north wall of the Lincoln Memorial. It's just a remarkable speech. It's Lincoln 41 days before his own assassination, trying to come to terms with the level of destruction and suffering caused by the Civil War. Pretty heady stuff. And he's going through, and he points out the irony that both the North and the South prayed to the same God, read the same Bible, and called on God's support to help them against their enemy. And then he pivots and starts talking about divine retribution and wondering whether or not slavery, which had been part of the country's history for 250 years, was something that was worthy of the retribution of God. And he has this incredible paragraph where he says, if we have to compensate for every drop of blood lost to the lash with another drop of blood drawn by the sword, basically so be it. And I've been thinking about just the magnitude of the cost of the U.S. healthcare system on the American people in terms physical, emotional, financial. It's incalculable. It's in these Lincoln-esque terms. So how do we begin to address that level of harm and begin a reconstruction process, which was really the message of the second inaugural address, was his empathy, his compassion, and his commitment to bringing everybody back together. So that's number one I've been just thinking about. Is this equivalent to that moment? Is this moment equivalent to that? So why?
Just one other thing
Yeah.
to add from his second inaugural address, with malice for none.
And charity for all. Exactly.
With that message, that's what made the second address.
Yeah. And let's go forth and do our work, right? We have a lot of work to do in healthcare. So with malice toward none, charity for all, let's go forth. It's beyond time that we embrace value and consumerism. It just is. So here's why I'm thinking about World War I. You may remember that the trigger event for World War I was the assassination of, I can't even remember the guy's name.
Archduke Ferdinand.
Ferdinand.
Who got that? Don't duck, own it.
Archduke Ferdinand. And if you read anything about that, they had to change the parade route because there were some blockages. The guy that actually killed him had given up for the day, was sitting at a bar getting a drink, and Ferdinand came by and shot him. At the time, Europe was basically broken, right? The diplomatic, economic relationships were fraying at the seams. So you had a broken system. And the assassination was the trigger event that sort of unleashed all these other macroeconomic, cultural, political forces. And we're sitting here with a very broken U.S. healthcare system, and we've just had this event that I think we're still all wrapping our heads around. And I'm wondering if we're going to look back in 5 years, 10 years, and remember December 4th, 2024, as the time when it turned. I think it could be that kind of event. The other thing I'm worried about is that we're going to turn this guy into Luigi, into some kind of cult hero, and I actually
A martyr.
I'm profoundly worried about that.
Yeah.
But you had another question about the forces.
I'll tell you what. Let me
Okay.
add one other element, and
Yeah.
I'll get you back on it. What is the role of government, do you think, over the next few years? When you say changes from the outside,
Yeah.
are you talking market, or are you talking government, or is there some hybrid, and what does that look like?
Yeah, I believe it's a hybrid. I mean, I have a degree in public policy, and unfortunately, when people hear market-driven solutions, their immediate conclusion is no government involvement at all. Government has a huge role, right? It's the largest purchaser of healthcare. It regulates the industry. It creates payment models. It is trying to stimulate innovation. It's the insurer of last resort. We need government to get it right. The fundamental problem with healthcare, our original sin, if you will, is that we have created a payment model that rewards volume and stimulates revenue generation and profits without it's not based on value. It's the old value volume thing. And someone has said to me, and I find this very powerful, the problem with the healthcare industry is at the end of each transaction, the principals don't see an individual, a human being. What they see is a diagnostic, a treatment, a bill, maybe a doctor, but they don't see a human being. It's not like other service industries. And you would think, given how important and how powerful the sort of challenges are relating to managing our health, that we would be more attentive to human needs. We're not. We're a very callous industry. And much of that comes from all this jockeying back and forth over who's going to pay for what. And we have I estimate that the revenue cycle business, which is the intermediary business, it's the healthcare audience, you know what I'm talking about. I think that's $1 trillion business in the United States. So there's the coding, the billing, the collection, the back and forth. That puts it at an equivalent size of banking in the United States. So we've got this whole industry out there spending $1 trillion that doesn't add anything to our economy. It's just the figuring out who's going to get what from whom. So our opportunity is to restructure in a way around value, and it involves moving to full risk-based payment models. What we say, Paul and I say, the disruptive innovation that's going to bring down the castle is something called 3D WPH, democratized and decentralized distribution of whole person health. Democratized and decentralized distribution, 3D, of whole person health. Our current system is disease-centric, crisis-centric, physician-centric. It gets into the game too late. It costs way too much. It's fragmented. So we need, and I heard some of that in the panel, we need to come up with payment models where everything comes together and we're centered on the individual, whole health, getting them what they need. And we're doing a much better job on prevention, on chronic disease management, and so on. And part of where I take some real hope is we're living in the midst of the two general purpose technology revolutions on what's going on with big data and what's going on with synthetic biology. And those two together have the potential to identify and intervene in diseases 3, 4, 5 years before they manifest. I call that preemptive diagnostics. So today we spend 3% of our healthcare expenditure on prevention. What's that in 5 years? What's it in 10 years? 10%, 15%, 20%? Any way you slice it, it's massively disruptive. So there are things to hang our hat on, but this is like pogo, right? We met the enemy and they is us. Healthcare, first of all, has to come to terms with its own dysfunction, and that won't be pretty.
So what would that process look like? Healthcare coming to terms with its own dysfunction? Because here's the challenge I see. By the way, I don't disagree with any of this. I've yet to
You're revolutionary.
I've yet to see it happen. You've got provider institutions, payer institutions that command these enormous organizations with enormous assets and resources. And Dave, you and I do the same thing, man. We go circuit after circuit, we listen to these folks get up on stage and they talk about the progressive things they're doing with ACOs and value-based payment and AI and compressing rev cycle spend and blah, blah, blah. And it's all garbage, right? They're not really doing any of that. It gets, right now, somebody tell me who actually, show me a healthcare CEO in this country running a major medical system or a major health plan that you believe is really trying to blow up the organization in a revolutionary way to do the right thing by patients. I understand institutions are subject to other structures and systems, and that's one of the challenges we have. But therein lies the problem, my friends.
Well, that's
those
why.
structures and systems, what blows them up? Because to me, it's not going to be the altruism.
So I actually think a lot about what are the trigger events. So the title of the book, the title we wanted for the book until our publisher quashed us mercilessly, was Gradually Then Suddenly. It's from Hemingway's The Sun Also Rises, which might be his greatest book. How did you go bankrupt? Gradually Then Suddenly. And
it's like when Elon Musk on Twitter said, how do you make a small fortune? Start with a big fortune.
Yeah, and it's the same thing, the S-curve in economics is this gradual change, and then you get to the inflection point. The forces that we describe in the first half of the book have been at work for a long time. We're a lot closer to the suddenly stage than I think most people realize. And by the way, I just got to share this because I couldn't agree with you more. I can't even go to conferences anymore. I just can't listen. So I call that MAFA, M-A-F-A, mistaking articulation for accomplishment. Come on. Come on. And David likes to say people admire the problem. They love to admire. Healthcare loves to admire its problem. It's a great line. But so I think about trigger events. COVID should have been a trigger event. Oh my God. Insurance companies made record profits and providers needed a government bailout. If that didn't get our attention, what did? So what's so depressing now? The AMA and others, there was real innovation during COVID, right? After we said, okay, you'll get paid the same for a video visit as an in-person visit, we went to 80, 90% video visits. We loosened regulations. We allowed people to cross state lines, practice at the top of the license. And now they're trying to put all of that back in the bottle. It's horrible. It's horrible. If I were a governor of a state, I think I could get elected president by saying, I want to be the healthiest state in the country. So what do I do now? What do I do near term? And what do I do long term? What I do now is first I announce we're going to be the healthiest state in the country. And I invite in MacArthur and Gates and Commonwealth and whoever else and say, what's that look like? And then they come back and tell us. And I challenge every other governor to also be that. And next thing, I do two things. I create two blue ribbon commissions. The first one is on overhauling all the medical education in the state. How do we practice at top of license? How do we do interdepartmental or interdisciplinary care, interprofessional care? How do we get more education in nutrition and so on? And basically, how do we become the state that makes it the easiest place in the country to practice healthcare? Instead of putting up medical protectionism, we embrace it. And the second thing I do, so I have blue ribbon panel. What's my first thing? Jeez. Anyway, I'll come back to that because I will remember it. So so what I do near term is I go to Washington and I negotiate the mother of all waivers that allows real payment reform. So you got to take real risk, and we figure out whether that's done with global budgets like they do in Maryland, whether it's fully capitated, however we do that, we negotiate that. And then the next thing I do longer term is I go to every school, every business, every church, and say, what are you doing to make us the healthiest place in the country? And we start to embrace the mission of health. And I forced myself, by the way, in July to listen to Robert Kennedy's concession speech. The fact that I said I had to force myself tells you probably what my political leanings are. And a lot of it was just outer space stuff. But he had the most cogent 15 minutes on the challenge that chronic disease presents the country that I've heard from anyone. It could have come right out of Foresight Health. It's one of the topics we talk about a lot. So how do we as a country embrace health? How did we get to a point where 70%, 75% of our young adults can't qualify for military service, where 70% of food served at schools is highly processed food? We're poisoning our kids. And Kennedy got to the end of his sort of section on this. He goes, we're at each other's throats. If we can't agree on how to make our children's lives happier or healthier, what could we possibly else agree on? And he's right. We have to figure out how to create a healthier country. We are on a very bad path. And the good news is, if we do spend more on health, we won't need as much health care. So how do we get that balance right?
I'm going to ask Dave one more question. When I'm done, I'm going to invite everybody to give him a round of applause. So do the same thing you did at the beginning, at the end, inject some energy. I got you, Megan. Then I'm going to thank our panelists. Please do it again for them as well. Last question for you, Dave. Fast forward 10 years, we've seen more change in that 10 years than we did in the previous last century.
Yeah.
Who is the biggest winner and who's the biggest loser?
Biggest winner are the American people. Better health care, lower costs, better customer service. We all have a bot on our shoulders that's helping us navigate an ever more complex world. Tell you whether you're eating an apple or an orange. I don't know what it's going to be, but the biggest winners will be the American people. I think the biggest loser is going to be the healthcare industrial complex, what I call Healthcare Inc. It's not only is healthcare the largest industry created by human beings, it's also far and away the largest industrial complex. And the organizing principle around my second sort of market book, the Customer Revolution in Healthcare, was I was really frustrated by the lack of incremental progress in the industry. It's not that there aren't breakthroughs. We've cured hepatitis C. We came up with the vaccine. We now have the GLP-1 drugs. We can do anesthesia within 30 seconds of when somebody needs to wake up. There's been progress, but the long-term trend has been ever more money spent for an ever sicker population. Why haven't we turned that around? And I found myself going back to Eisenhower's farewell address, General Eisenhower's farewell address, which I think, by the way, is one of the greatest presidential addresses in history, not for the way it's delivered, but for the content. And he was the first one that identified the military-industrial complex. That was his language. And he said the conjunction, it was new in America. Every time before when we'd gone to war, we flexed up and then we flexed down for peace. And because of nuclear weapons and the Soviet Union, we needed a full-time armaments industry, but we had never done that. So Eisenhower, with all of his experience, worried about, and he used words like grave threat that was political, economic, and spiritual in nature of a conjunction, which we all know now, the conjunction of business or industry, bureaucracy, and Congress working for their collective interests at the expense of society. So 1960, when he gave that speech, January 61, military was 9% of the economy. Healthcare was 5%. Today, military is 3%. And oh, by the way, we've got a military-industrial complex. Healthcare is 18%. We have the equivalent, when you think about the bureaucracies, the fact that the state legislatures, the federal legislatures, then the massive industry, we have the equivalent of the military-industrial complex on steroids in healthcare. One thing we have to do is we have to break that because it's so powerful. All you have to do is look at the surprise billing legislation. That was one that I thought everybody agreed on. Nobody should get a bill for gazillions of dollars for people they'd never met that they didn't approve. And what we ended up doing was passing some watered-down arbitration thing that will help a few people, but actually just keep costs going up. So that's your big winner. That's your big. By the way, the two blue, I mashed together my two blue ribbon commissions. One is on what to do with healthcare professionals. How do we get them practicing with one another on the right things? And then the other was on regulation, being able to cross state lines and so on.
My favorite quote from Winston Churchill is, "Americans always get it right after they've tried everything else." I feel like over the last 80 years or so, we've checked the everything else box. Like hasn't been for lack of trying. Government reforms, I think some industry reforms. I think the things you highlight in the book and the things you've highlighted tonight articulate a really good point of view on why we are where we are. And I think you postulate a really compelling vision for why we can go to a different place. And I'll wrap with this, that we talked about 19% of GDP. Should we spend more? Should we spend less? We'll have that debate. But picking up on something you said a minute ago, Dave, on the other hand of all of this, it is incredible what we do have. Medical institutions that are best in class, world class, pharmaceutical innovation, training, graduate medical education, evidence-based methodologies and applications and research. We really crush it as a country on building the infrastructure, but when it comes to allocating the infrastructure in a way that it can be accessed and done efficiently, we're terrible. I think what you've outlined gives a compelling reason for us to get to that place. I'm going to invite everybody in here I think you're going to get a copy of this tonight before you head out. Breeze past chapter 4 with me, finish the book, and we'll all have our marching orders as we walk into a new year. I'll say this, the last thing. I am optimistic about the next 10 years. I truly am. But I will also tell you that over the next 2 or 3 years, that's not going to be nothing either. The pace at which things are changing in the world, in this country, in our healthcare system, are of such a pace and magnitude. We are literally, every year, we are living 5 to 10 years of cultural movement at a time. It's incredible. So it's an incredible moment to be alive. It's an incredible moment to see the problem we have just laid out at our feet. And it's time. It's time for revolution. It's time to break some shit. And Dave, I'm glad you're here. I'm glad you're thinking so critically about it. Please join me in thanking my friend Dave Johnson.
Yeah, thank you.
You guys nailed that. You even had the 5-second lag. That was great. Also, big thank you to Ryan, Esther, Carolyn, Dave, and Jordan. I can't believe I got it. I've gone through that in my head like 30 times. Please join me in a round of applause for our panel. Thank you so much to each of you for being here this evening.
On behalf of Third Horizon and HC3, I want to thank you for joining us and for our continued work together ahead.